Hello, this is Dr. Jabour. I'll be discussing Blinatumomab for minimal residual disease in adults with B-cell ALL, published recently by Dr. Kokbiji and her colleagues in Blood 2018. In summary, Blinatumomab was found to be effective in patients with positive minimal disease. In a way, 80% of them were able to convert into MRD negativity and subsequently getting transplantation. The importance of this article resides in the fact that we know historically patients with positive minimal disease, they do not do well. They can go for transplant, but they have a high rate of relapses. At least here, Blinatumomab is converting this patient into MRD negativity and improve the outcome at the long run. Do we still need a transplantation? The answer is yes today, but at least nobody today should get transplant in MRD positivity before being able to receive a Blinatumomab and convert into MRD negativity. So let's look at the method of this trial. In this open-label single-arm phase 2 study, 116 patients aged 18 or older with B-cell ALL in first or later CR with persistent minimal residual disease at 10 to minus 3 and above, after a minimum of 3 blocks of intensive chemotherapy, were eligible to receive a Blinatumomab at a dose of 15 micrograms per meter squared per day by continuous infusion for up to 4 cycles. Each cycle comprised 4 weeks for Blinatumomab infusion, followed by 2-week treatment-free period. Patient could undergo allogeneic stem cell transplantation at any time after cycle 1 at the discretion of the investigator. Prophylaxis for central nervous system was recommended before cycle 1 and after cycle 2 and 4. Overall, 76 patients underwent bone marrow transplantation in continuous CR after 1 in 27 patients, after 2 cycles in 36 patients, and after 3 or 4 cycles in 13 patients. Mrd evaluation for eligibility was performed mostly in a central reference laboratory or in national reference laboratories using real-time quantitative polymerase chain reaction or PCR of clonally rearranged immunoglobulin and O T-cell receptor chain rearrangement or using flow cytometry. The central reference laboratory exclusively performed MRD assessment at baseline, at the end of treatment cycle, and during efficacy follow-up using real-time PCR. The primary endpoint was the rate of complete MRD response after cycle 1 among patients in a primary endpoint full analysis set, or 113 patients, which excluded patients from the full analysis set with either no central MRD as a result or a test sensitivity that did not reach 10 to minus 4. MRD response was evaluated among patients in a primary endpoint efficacy set, or 103 patients, which excluded, in addition, patients from the primary endpoint full analysis set without hematologic CR with MRD less than 10 to minus 3 at study entry. The key secondary endpoint was hematologic relapse-free survival at 18 months after initiation of a Blinatumomab, and that was evaluated among patients in a key secondary endpoint full analysis set of 110 patients, which excluded patients from the full analysis set who had either Ph-positive disease or 5% and more bone marrow blast at study entry. So essentially, these are patients with a Ph-positive, we can follow them by PCR, or having morphologic disease defined by 5% and more blast. So what are the key findings of the study? For 113 patients with evaluable MRD markers, 88 or 78% achieved a complete MRD response after cycle 1. That was the primary endpoint. So essentially, 80% almost of the patients did achieve this endpoint, which is MRD negativity after cycle 1. 2 additional patients achieved a complete MRD response after cycle 2. No additional patient achieved a complete MRD response after cycle 3 or 4. That means responses do happen usually after 1 course of treatment or maximum 2. Patients who do not respond after cycle 1 and 2 usually should not get further therapy. Among 5 patients with a Ph-positive disease who had MRD evaluation, 3 patients or 60% had an MRD response during cycle 1. Now for the 103 patients in CR, with MRD positivity above 10 to minus 3 at baseline, 91 or 88% achieved any MRD response, including 82 or 80% with a complete MRD response after cycle 1. complete MRD response rates were similar between patients with MRD above 10 to minus 2 at the baseline and those with MRD below 10 to minus 2 at baseline, and between patients with first remission and those with later remission baseline. So all the responses were seen across all the board. Among 110 patients who had a Philadelphia negative disease and less than 5% of us at the baseline, the Kaplan-Meier estimate for relapse-free survival at 18 months was 54%. Median relapse-free survival was 18.9 months, with a median follow-up of 29.9 months. Median relapse-free survival was 11 versus 24.6 months among patients treated with a later CR versus those who were treated in first CR with a hazard ratio of 2.09. Patients in first CR also had an improved overall survival compared with those in a later CR. Of 110 patients, 48 remain in CR, 36 after subsequent allogeneic bone marrow transplantation, 38 relapsed, and 24 died in CR, 20 after subsequent transplantation. The median duration of remission was not reached. And by remission, I mean hematologic remission. Median overall survival was 36.5 months for the whole cohort, with a median follow-up of 30 months. Among the entire study population of 116 patients, the median overall survival was also 36.5 months. In landmark analysis, the landmark of 45 days was used to represent the latest day of first MRD response assessment. The median relapse-free survival was 23.6 months versus 5.7 months, p-value highly significant, and the median overall survival of 38.9 months versus 12.5 months, p-value as well highly significant in patients with and without MRD response after cycle 1 respectively. Of the 110 patients in a key secondary endpoint full analysis, 74 or 67% underwent allogeneic stem cell transplantation in continuous remission after Blinatumomab, 55 in ongoing first CR, and 19 in continuous second CR. Of 36 patients without transplantation or chemotherapy after Blinatumomab, 9 or 25% remain in continuous CR with a median follow-up of 24 months, whereas 36 or 49% of 74 patients with transplant remain in remission. Overall, 33% and 27% of patients had grade 3 and 4 adverse events respectively, including 20% and 18% respectively in cycle 1 and 11% in cycle 2. Investigators considered grade 3 and 4 adverse events to be treatment related for 29% and 22% of patients respectively. 4 patients, 3%, had cytokine release syndrome, grade 1 in 2 and grade 3 in 2, all during cycle 1. 61 patients, or 53%, had neurologic events of any grade with decreasing incidence over cycle 1, 2, and 3, and 4 of 47%, 24%, 15%, and 15% respectively. Neurologic events resolved in 59 patients, or 97% with any grade events, and in all patients with a grade 3 and 4. Most patients who had grade 3 and 4 neurologic events resumed Blinatumomab treatment after the event resolved. 2 fatal adverse events were reported during the treatment period before, both in cycle 1, atypical pneumonitis with H1N1 influenza, considered treatment related by the investigator, and subdural bleeding, considered unrelated to the treatment by the investigator. So here's the study about the Blinatumomab in MRD positivity. What that means, what are the important features, or what the important elements reported in this study. I think we all know that the assessment of minimal residual disease should be part of our standard of care today. And patients with positive disease, usually they have a poor outcome. In fact, MRD is not a biomarker. MRD means somebody has persistent disease, and therefore we call it minimal measurable residual disease, not only minimal disease. It's measurable. We measure this disease. We all know that if you have an MRD positivity today, the outcome is poor. And you go for transplant because it's better than chemotherapy, but we know clearly as well that transplant does not improve the outcome of this patient to the level observed in patients who are MRD negative status. So blinatumomab is the first drug that have shown the capability of converting these patients to MRD negativity into MRD negativity. 80% of the patients were able to get to MRD negative status, and eventually going for transplant thereafter. No, the study had its limitation because it's a phase 2 study, it's not randomized, although I doubt that very much you can get a randomized study today for patients with minimal disease positivity. You cannot randomize into blina or no blina, so that is a given. And then the question of transplant remains unanswered. Do we need a transplant for this patient or do we not need a transplantation? Today, I'll say standard of care is transplantation, although we do see there's patients who receive a blinatumomab without transplant remain free of disease down the road. Therefore, there will be a subset of patients who can be cured with a blinatumomab alone without transplantation. So these are the studies today. I think as standard of care, somebody who's into chemotherapy after 12 weeks remaining MRD positive should get blinatumomab before considering transplantation, 1 course or 2, and then going for transplant from there. We're exploring the role of maintenance with blinatumomab post-transplantation or without transplantation as well. We need to improve on the MRD assays, whether use flow PCR or next generation sequencing. These questions are still unanswered. So we need to have the MRD assessment part of our treatment algorithm and have a blina offered for this patient if they are MRD positive status. So moving forward, what are the unanswered questions today is, again, to see whether the role of transplant is needed, yes or no. The second, what is the best tool to assess for MRD? And then improve the cure rate for these patients.